little bit to our. Hello and welcome to the 27th Degree with Chris and Nancy. So today our guest is Pam Bolarinho, a licensed social worker and the ESP Program Director, Child and Family Services. She joins us to discuss the co-response program, which we'll hear a little bit about in a few moments. But before we begin our conversation, I'd like to thank our sponsor, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. As always, you can support the 27th Degree with Chris and Nancy by signing up as a patron. Go to patron.podbean.com/the27th Degree, or you can click on the link on our Facebook page. $5 a month gets you a shout out, bonus content, access to Basement Bites, which are my music videos, and a behind the scenes look at taping before and after the show. You can find the 27th Degree across social media, including Facebook, Instagram, and your favorite podcast platform. You can also subscribe to the 27 Degrees Consulting channel on YouTube. I'd like to give a big thanks to Ron Gamache for our intro music and EBM Studios for producing our show. So we'll get right into this. Tell us a little bit about yourself first. Why don't we start with that?
Okay, great. So I'm Pam Bolarinho. I'm an LICSW and currently the Director for Emergency Services at Child and Family Services. So before I came to Child and Family, which is now going to be 4 years in October, I have been a social work manager at an acute hospital, as well as a clinical director at a psychiatric facility. And also back in the day, before my master's, I also did child protective service work. So I've had a little bit of everything, including doing some, we were chatting earlier, some per diem work with South Coast Hospitals Group. So mental health has been something that I'm so familiar with. Child abuse is something I'm really familiar with. Substance abuse is something I'm really familiar with, and it's something I'm comfortable with. So I will tell you a little truth. I thought I wanted to leave the world of social work 4 years ago, and I went into healthcare recruitment, and I think I cried every single day. I was miserable. I did really well financially. It was a great place to be at, but I think I cried every day, to the point my husband said, enough, you need to get back into it. So back into it I went, and best decision I've made. I worked most of my career outside of the area that I live. So I live in New Bedford, and I've always worked outside of New Bedford. So the South Shore area here in Fall River for many years, but never in New Bedford. And this is the first time I'm in my community, and it's such an eye opener for me because I feel like I'm doing the work that I love, but I'm also doing it for the community that I love. So to see the change happening right in front of you as you're doing the work is pretty significant.
That's a great matchup too. When all those stars align, it's such a great feeling. And then if you missed it that much, this is your true calling.
Absolutely.
So we're so fortunate to have you on today.
Thank you. I appreciate it.
Can you tell us a little bit about the program? Can we start with that?
Sure. So I can tell you a little bit about let me just tell you about emergency services, because the co-response falls under the emergency services.
That'd be great.
So the state as a whole has what's called the emergency service program. Everyone knows it as either ESP or the crisis team. So every single area, catchment areas we call it, will have their own emergency service team. So for us, we cover Dartmouth all the way to Hanson, Mass. So we have 17 towns in a city. Plymouth is considered a town, but it's honestly more of a city than it is a town because it's really big. So we have our main office, which is in New Bedford, and the main office in New Bedford is the 24/7 site where all the calls come into. So it's our call center. And then we have a satellite office in our Plymouth area. And that satellite office, although it's staffed 24/7, the office closes around 10 o'clock at night, just more so because for protective reasons, we don't want our staff by themselves out there. versus in New Bedford, we have security. We never close. So it's a little bit different. So what emergency service does is we are the state contract to do all the crisis evaluation. So a lot of people know it as a psychiatric eval. So we'll get a call, say from St. Luke's Hospital, and they'll say we have a patient that needs to be seen who is exhibiting some depressive symptoms. The staff will go out, a clinician, which is a master's level clinician, will go out, evaluate the individual, and then talk to an administrator on call and say, here's what's going on, here's my recommendation. So recommendations look all different, right? It could be somebody just, needs a referral to an outpatient provider, or somebody needs like a partial hospitalization program, which is a daily program for 2 weeks, but they can go home every day. Or they need the crisis stabilization unit, which is right on our site, which is a 9-bed adult unit.
That's an inpatient unit.
Yeah, but it's a voluntary.
Okay.
So that's the difference. So, and then, or if it's a child, we have a voluntary child unit, which is 9 beds as well. Or if they need a higher level of care. So the higher level of care is a psychiatric facility, which is involuntary. So that's what we do. We determine the levels of care, and then we allow the provider at the emergency room to know, like, this is our recommendation. And most of the time they typically agree. And if the person, and then we finish it. We make the referrals. We follow up with them out in the community. If they need additional follow-up, we can follow up for like about 7 days. So we'll follow them for about 7 days, whether that's a phone check, have them come into the office, or we'll meet with them via Zoom or at their home. Or, we do the referrals. We'll connect them with a psychiatrist, with a therapist. We do all of that. And if it ends up being somebody that requires what we call a higher level of care, we own that, meaning that we don't hand that off to social work or the hospital. We actually do the bed search ourselves. Okay. So we have clinician assistants that will actually do bed searching. So they call all the psychiatric facilities, find out what they have for beds, send the referral in, and then we finish off the case and transfer the patient once a bed is identified. But as an emergency service team, one of the biggest things that the state is looking at, and rightfully so, is how do we avoid people going to the emergency room? Mm-hmm. Some people, if you have a private insurance, you're going to end up with a copay.
Right.
If you don't have insurance, you're going to end up paying out of pocket. So we do all uninsured. We're contracted to do uninsured. No one's going to get a bill if they're not insured, if they see us. So we just, we've been doing a lot of marketing and work about how do we capture individuals before they get to the hospital, right? How do we see you in the community? Because ultimately that's what we want to do. We never close. Our office is always open. So it's not like we don't have a space that's safe for you to come to meet with us. So it's been one of the things that we've been really, really focused on. And the state as a whole has said, okay, we want to reverse the numbers. So right now, I would say about 2 years ago, it was about 70% of patients were seen in the emergency room and only 30% in the community. Mm-hmm. And the role is to switch it. Okay. 30 in the hospital, 70 in the community. So we're seeing the numbers go up where we're doing more and more community-based. But the community-based is really getting an outpatient therapist who might send somebody to the hospital instead calling us. Right. I have this individual in my office. They're not doing well. Can need a crisis eval. Absolutely. We have an hour response time. So the minute we get a call, we have to respond within the hour. That is what's expected of us from the state. And I will say we average about a 27-minute response time.
That's fantastic. So, and I can tell you just something really important as part of my former role as the quality manager for some emergency rooms, that our bed count for psych beds, if we had a 51 treatment spaces in one particular ER that I worked in, most of the time at least 22 beds were taken up by psych patients.
It's a common problem in the emergency
and then
that we're dealing with.
And then that transfers into wait times. It transfers into just availability of space. It's a big deal to increase that number and to get the appropriate resource for people.
And it ties up a lot of resources within the emergency room. Right. And it also causes a lot of stress to the patient themselves. Sitting there for hours upon hours, not knowing what's happening, waiting for the team to come in because we can't go in until they're medically cleared. So that could be 6, 7, 8 hours. I mean, if you think about it, St. Luke's is an extremely busy emergency room. So by the time, it can take a long
One of the
time
busiest
before.
in the state. I don't know if
Right.
people realize
It's
that.
also,
yeah.
I think it's stressful to the staff too,
Of
It's
course.
very stressful
You
to
know.
them.
because they, some of the psych patients end up there for a long, long time. Because as you know better than I do, sometimes it's difficult to find resources in the community. So
Take an uninsured
they can be there
patient.
for a while.
Right. Take an uninsured patient and they don't have any insurance and they go to the emergency room and they require an inpatient psychiatric admission. You're looking at state facilities to accept them. And if there's no beds, they're sitting there waiting in order to get a bed. So what we like to do is be able to say to somebody, before you get to the point that you need to go to the hospital,
Right.
call us. Let us be an intervention versus a crisis. We'd rather get called when you're starting to exhibit symptoms versus calling us when you're in a full-blown psychotic episode.
Right.
How do you get that message out there? Like, what's been the effective ways you've really
Yeah.
done well with that messaging?
So we do a lot of, we have a great marketing person that works for us 20 hours a week. She does an incredible job really with our social media and getting the word out there. We participate in a lot of community meetings. We are very close with the school departments.
Nice.
So we build a lot of relationships with the schools. We build a lot of relationships with outpatient providers, psychiatrists, therapists. So the more that they get used to us and the more they realize like this works, like pediatricians' offices will call us, then they'll use us more and more. So it's really just making sure that you just don't say you're going to do something, but that when they do call you, that you actually follow through so that they know it works and they call you more often.
I like the idea that, you're trying to prevent a crisis basically, because what we see in the emergency room is once they get there, the patient gets there, if there's no bed available, they can sit there for days, sometimes even longer.
Yeah, it's not hours.
It can be
days.
really a very long and probably uncomfortable wait for the patient. And it as you say, it affects the resources that the ER has to offer other patients in many instances. So it's great that you're working to be proactive to do that. So who's calling you? Is it, you said offices, ERs, obviously.
Anybody can call us.
It can be a person out in the community that is having a difficult time. They can reach out to you.
Correct.
Okay.
So anyone can call us. The referral can come from anyone. So it could be the patient directly themselves. It could be the parents. It could be the schools. It really can ultimately be anyone. And we've had times where we've had a neighbor call to say like, hey, I don't think my neighbor's well. If somebody can come out and check on them. So it gets a little tricky if it's not the patient themselves, because ultimately you want the patient's buy-in to do an evaluation. You don't need it, but you want it because they're more likely to have more successful evaluation if they agree to it. If you have somebody that's like, I absolutely don't want it, but you still need to complete it because they're at high risk and you need to determine if they're safe to be out in the community, it's a little bit more difficult. So if you're a newer clinician and you don't necessarily know the language to use and how to encourage somebody to really participate in an eval, it could be a little bit more of a struggle. But most of the time, it is just about, it's usually schools, providers, and patients themselves and family members that call us, or the police department.
So you capture the whole age spectrum.
We do.
It's like everybody.
Correct.
Can call.
Correct.
Yeah. What kind of diagnoses are you dealing with? Just so our viewers have an understanding of the types of mental concerns, mental issues.
So we have our chronic individuals, right? Our chronic individuals would be somebody who suffers from bipolar disorder, somebody who suffers from schizoaffective schizophrenia disorder. Those are the more chronic that we tend to see are repeaters, no fault of their own. If they go to a psychiatric facility and that psychiatrist chooses to change their medications around, and then they come home and they don't like how they feel and they don't have someone to follow up with them, or they are waiting 3-4 weeks before they see their own outpatient psychiatrist, they might take themselves off of it because they don't feel good. So we'll see a lot of that. But it's a lot of like anxiety disorder, depressive disorder, a lot of adjustment disorder for the kids, especially this past 2 to 3 years. We've seen a lot of adjustment disorders, a lot of dual. So individuals suffering for either depression, anxiety, bipolar disorder who end up with an addiction issue as well. So a lot of the dual type of things we see too. But I would say majority of the patients that we do see, probably about a good 60%, would fall under the like bipolar, depressive, anxiety, dual. And then about 30 to 4 would be more the chronically sick individuals.
It's really the full gambit of mental illness.
It is.
So, I mean, you're covering everything that's
Yeah, you
out
see
there.
eating disorders. Yeah.
What are the adjustment disorders? What does that mean?
So you can see a kiddo who maybe was just removed from their home and placed in foster care or in a group home, and we're seeing them and they're having a difficult adjusting. Or, you know, a child that moved from one school to the next and is having a hard time adjusting to the environment there. So that's where the adjustment disorder tends to come in.
Okay, great. So this co-response program then, what was the origin of that? How did that come about? And what is it?
Yeah. So it's really exciting. And I was just telling you earlier, and I can talk a little bit about it. We had a huge event on Thursday for it. So it's going to be 4 years in September. I was attending a community meeting at the local police department, at New Bedford Police Department, and the previous Chief Cadero, was chatting with me at the end of the meeting. And he said, you know, Pam, I really could use a clinician to be part of the police department. We do so much mental health, and these officers are just not equipped for this. And, you know, and they're not trained for it. So he's like, I really wish we had it in our budget. So I just said, I don't even know why you need to look in your budget. We're your local emergency service team. Our responsibility is to respond to the community for anything to do with mental health. So I said, so why don't you just let's work it out. Let's figure out how to do this. So we decided.
His eyes must have lit up.
Yes, it did. And we worked on some details, and we were lucky enough at the time, who had been employed with us for quite some time, a clinician who had been previously a military police officer. So he agreed to pilot it. And the reason I say that is we're lucky to have that is because the language within the officer, the police community is a little bit different than our language.
Right.
So somebody who is accustomed to that, it's easier for them to not only adjust themselves, but for the officers to accept as well, because this is something new. So initially for an officer, it's like, okay, who's this person? And are you taking part of our jobs away? And it's like, nope, we're just complimenting you, and we are here to be your support, and that's all we are. So we came in for the first 2 weeks and as a pilot, and we realized that it was actually really successful. What was happening is that they were getting calls to mental health calls, and our clinician at the time would go out with the officer and would be able to de-escalate the individual, would be able to do an evaluation right on site, would be able to hand it off to the team that's back at the crisis team and say, hey, this person needs an outpatient referral. They need a psychiatrist. They need the crisis stabilization unit, and hand it off to the team. And we would take over from there, and off they would go to the next call. So the calls themselves were not taking up as much of the officer's time as it was before. Because when they were going without a clinician, they were taking a lot more time, because it's not something that it's not that they're not used to it because they're going out on mental health calls all the time.
Right.
But there's a skill set that you have that they don't have, that we do. And that's the piece where we're able to go figure out in the moment, is this person a risk to themselves and others? And if they're not, let's get them what the services they need. Or if they don't need anything, then we leave. So the time spent there decreased significantly for the officers. They also realized that the amount of patients that they weren't transporting to the emergency room decreased significantly. We were able to, stabilize them in the community and not have them go to the emergency room.
That must have reduced their stress a lot too.
It does. It reduces their stress. It reduces their paperwork. It reduces the time they're out on a call.
And it probably reduces repeat calls.
Yeah, it definitely does. It was a lot of new business for us too, because there was a lot of individuals that we weren't aware of that were suffering from mental health, that they were getting called out a lot on, that we were end up meeting with them and saying, hey, you have this team out there that can help you and guide you and give you the services you need. You don't have to call the police for this.
Right. So there must have been this great downstream effect from that. I mean, for the police, obviously it was helpful because it took some of that burden off them. And, for the emergency rooms, it also unburdened them too. But I want to understand the logistics of how this all works. So do you ride in the cruiser with the police? Do you show up separately? Do they call you?
Nope. So they ride along with the officer. So I have a clinician Monday through Friday from 8 to 4 with the Bedford Police. And I actually have two clinicians. One does Monday and the other one does 4 days a week. And they ride along. So they have an identified officer of the day. and they ride with that officer all day. And they are going out to mental health calls, but they're also going out to non-mental health calls at times. So if there's nothing going on and there's like an accident, they're right there and they're in the cruiser waiting for the officer to finish.
Interesting.
They've also been very helpful for things like that, because sometimes they come out of the car because the individual's like stressed out and there's an accident, tearful, and they're able to console them and meet with them. You know, unfortunately, they've gone to a lot of, you know, successful suicides.
Wow.
So they're able to at least provide support to the individual's, you know, family members, and also to the officer as well, even though, you know, officers might say like, I'm good, like, but you don't realize the aftermath. The thoughts that cross your mind and those images that consistently cross your mind, and having a clinician be able to talk you through it and at least just be an ear to sit there and listen to you without you realizing that they're actually like supporting you and guiding you and giving you the emotional support that you need. But so that's one of the things. And, you know, we've had a couple of really tragic things that have happened on calls that they've gone out on, including, you know, shootings where, you know, individuals unfortunately passed away, and we've had a clinician right there to support the, you know, whoever was around there. So it's not just about the mental health calls. And it's interesting because I was doing supervision with one of my staff this morning that does the police co-response, and she does it for the Plymouth area, and we can chat a little bit more about that. And she said, Pam, I'm going out on like follow-up calls. Is that okay? And I go, of course it is. Because even though we don't get paid for any of that work, you're still letting someone know that we care about them. We want to hear their story. We want to support them. It doesn't mean that we have to do an evaluation. So that was, you know, so we do a lot of follow-ups as well.
So when a call comes through, like how is it identified as a mental health call, and what qualifies as a mental health call?
Yeah, so that goes through dispatch. So dispatch, they determine if it's a mental health call or not. And to be honest with you, I couldn't quite tell you exactly what they're looking for. But anybody,
calls that.
So if it's a wellness check, that would be, you know, a wellness check would be a mental health call, suicide, attempted suicide, or somebody who's expressing suicidal thoughts would be a co-response program call. So those are the type of things that they usually would go out on, where, or somebody that is unfortunately out on the street, found passed out, you know, they would go out on calls like that. But it's really dispatch determines when the clinician should go out.
So what kind of gear do you wear? Are you wearing like a, you know, regular clothes? Or are you wearing like a vest?
Yeah.
Or,
Yeah. So our clinicians all have vests. You know, our clinician in Plymouth wears hers 24 at all times, never takes it off. It's part of her uniform. Our New Bedford clinicians just keep it in the cruiser, and when they come out, they just put it on. But they do have vests. We purchased vests for them. We wanted to make sure that they were protected when they're out on the field. So they have that, as I call it, security blanket. So when they need it, they put it on. So yeah, they have that. They also have the radios. So they each get a radio. So when there is a call, they can hear what's going on, and they're picking up the pieces because we gave them iPads. And what they do is they go right on the iPad and see, is this somebody that we've seen before? They can also go and look at Epic, right? If it's somebody that, because if it's not our team, we can say to social work, like, hey, this patient's coming to you. Here's what's going on. So it makes it a little bit easier.
That's great for continuity and following like a treatment plan that's already been established.
Correct.
You know?
Yeah, having the ability to check if it's somebody we've seen before makes a big difference.
Oh my God, yeah.
Now, do you go outside of New Bedford and Plymouth here? Do you go to Fall River too?
No, we don't. So we start in Dartmouth and we go all the way to Hanson. So Fall River has a separate team. It's the Bay Cove team. That's the emergency service team here, and I believe they cover Fall River in like 4 towns.
It's similar to what you're doing.
So they don't have a co-response active yet. I know they're in the works of getting one going. There's been, I had previously talked to their director who has left, and she did tell me that they were starting to have a discussion with the local police department
Seems
here.
Like every community should have this.
They should, absolutely.
So what happens, you know, you said that there's a spectrum of triage that you'll identify the appropriate resource for. You know, I understand there's such a wait to get in to see a psychiatrist. You know, do you have a quicker timeline?
So I have, and I'm going to toot my staff. My staff are amazing, absolutely amazing. We have clinician assistants, which are bachelor's levels clinicians that do the bed searching, but they also will look for the referral aspect of it. We have a family partner who is somebody that has their own child that suffers from mental health who is able to identify with a parent to say, I've been there, I know what the struggles are, who also makes the referrals for all of our kid cases. And we also have a peer specialist. A peer specialist is somebody with lived experience who has their own mental health, but they're stable and they're able to relate to a patient and say, I've been in your shoes, I know what it's like. They make referrals.
That's nice.
Yeah. So what happens is they build these wonderful relationships with our outpatient providers, to the point that we end up getting our patients referrals and into treatment so much quicker than if they call themselves. So a turnaround time is much quicker when we start to make the referrals ourselves.
Do you have psychologists as part of your group, or you're referring out to psychologists?
We refer out to psychiatry, social workers, LMHCs, and psychologists.
But you don't have them working for you?
No.
I think, do you want to do our commercial break?
I think it's time, yeah. We'll come back in a bit.
ProCare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. PrimaCare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. PrimaCare is large enough to take care of all your medical needs, but small enough to care for you personally. PrimaCare is by your side.
Welcome back to the 27 Degree with Chris and Nancy. So we're here with Pam Bolarinho, licensed social worker and program director, Child and Family Services for the ESP program. And we're discussing the co-response program, this is really fascinating.
Yeah, it is.
With the clinician that rides around with the police officer, do most of the calls go into them then, that like one car, and they'll go around?
So there's a couple of ways. So they either dispatch will call the cruiser and say, I need we have a mental health call, we need the clinician, so they'll go off. Another way is we get the call at the crisis center, and we know it's too risky for us to send just the clinician out alone. So we'll call dispatch and ask them to send the clinician out with an officer.
Okay.
And we also do this in Dartmouth, but in Dartmouth we don't ride around in the cruiser just because their volume is not as high as New Bedford. Right. So we dispatch from the office. So a clear example is the other day, they called in, they needed a clinician. Off I went myself and met the officers there. And it's typically the same officers who we're so used to each other. And I just, they wait for me to get there. The positive is that by the time I get there, they've made sure that the scene is safe for me. So when I get there, I could just do my job.
Right.
And, I always say this, and I know New Bedford is very protective of our clinicians, but when I tell you Dartmouth is protective of us, I can't even begin to tell you. I could be with an elderly woman and say to them, like, I'm good, you guys can leave. Like, I don't need you to stay. Like, nope, we're staying. They're very protective.
That's twofold too, because then they get to see what your approach is and what your language is and how you address certain situations.
Yeah, they probably learn a lot.
They're learning this like whole time. I mean, it's just like such a win-win program.
So it's a good way to explain why we had an event on Thursday. So as part of the co-response, you have the similar officers that are going out on these calls and are out with the clinician. And we decided that we needed to acknowledge an officer a year that we've been doing this program for exactly that reason. For them actually not only having the skill set that you need, but the empathy and just being kind and compassionate. So we, on Thursday, had a huge fundraiser and acknowledged two officers, one for 2020, one for 2021. And that was exactly what we were looking for. We asked our clinicians to identify one a year that they felt had compassion for these patients and empathy, and were willing to be patient to hear their stories. And we were able to acknowledge two officers, and they were both incredible, and they were taken back by it. They didn't expect it. They're doing this job every single day, not looking for recognition, but we felt they deserved it, and it was really great.
That's great.
It's so important sometimes to have someone show you how to be empathetic towards a situation. Like the light goes on sometimes. We had a particular nurse in the ER, and she was great with this population. And just like to see her interact with the patients and the clientele, like other people just followed her lead. You know, it's like, oh, there's another way to handle this.
Lead by example.
Yes,
Exactly.
yes.
Yeah, I think one of the biggest pieces that I always say to folks about this program is it's not just decreasing the amount of patients that go into the emergency room. It also has decreased significantly how often an officer puts his hands on a patient.
Okay, that's a good point.
And that has been huge. I was looking at the statistics last week for our fundraiser, and I believe they only have gone hands-on 6 times in the almost 4 years we've been doing this.
In 4 years.
Wow.
That is huge. So when I say hands-on, is that this person is escalated, they're not doing well. Sometimes the officers have to go hands-on in order to restrain them, or in order to put them in cuffs, to put them in the cruiser to get them to the hospital, just because this person's not cooperative, and that's the only way they could do it. By having a clinician be able to talk to the individual and de-escalate them and really just get them to just come with us. Like, when we're just going to give you a cab, as they call it, we're just your taxi. Their patients are going in the cruiser without having anyone go hands-on on them.
That's great. Because once you get to that point where, someone has to be restrained, there's so many bad things that could happen.
Absolutely.
Even though everyone's trained well and they're experts, things occur. So that's wonderful that you're able to intervene prior.
Just the relationship that the community has with the police
That's
force
important too.
has had to improve, with programs like this, especially because of the prevalence of mental health.
Yeah, I believe so. We know the program's successful. We've seen over 500 and something patients in the almost on the 3 years that we've done it, and only about 76% of them, 76% of them stayed in the community.
Okay.
Wow.
So, only 24% of patients going to the emergency room. That's huge.
That's really
tremendous.
huge, because it had, before this program was initiated, like you said, those numbers were so high, and it was just like the default. And now that default isn't in place anymore.
Yeah, I mean, and if you have to go to the emergency room, the benefit of the program is that we've already evaluated you. So by the time you get to the hospital, our team at the office is already bed searching for you. So your length of stay in the emergency room decreases significantly, because we're not waiting to get a call from the emergency room to say this person's ready to be seen 6-7 hours later. We've already done our piece. We're bed searching, and once we find a bed, all we say to them is we just need med clearance and they're ready to go. So it does decrease significantly the amount of time you stay in the emergency room.
So we talked about the impact of the police force and, the impact of the emergency rooms, but the patients, when they see you come out and start talking to them when they're having like a mini crisis, that has to be so calming. And it's like, oh, wow.
Yeah, because they're in regular clothes, right? They're not in uniform. They're in regular clothing, and they identify themselves right away. They have their emergency service badge on them, and they say, I'm a clinician. I don't work for the police department. I'm here to help you. And there is certain language that you have to use. So when they're able to say, like, okay, this person's not here to cause me any harm or to put me in jail, they're a lot more eager to talk. And be able to say, and one of the things that our clinicians always say is, listen, we're not here to take you away. We just need to talk to you so that we can keep you here. So let's chat. And once they're able to do that, and and it takes a certain clinician to do this job, just so you know.
Sure.
But once you're able to do that, you're more likely to have a patient participate and not have their walls up and let their guard down.
When do you have the most calls? Like, is it during the day?
It is during the day.
Usually?
So
that surprises me for some reason.
In order to do the program, one of the things that we ask is for us to give data of when the most calls come in, because what I didn't say is that we don't get any funding for this. So unless, it's, even though we're contracted with the state, if it's not an insurance that we contract with, we're not going to get paid for it. So at the end of the day, it's still the right thing to do, is to do this, whether we're getting paid for it or not. So one of the things that I lost my train of thought. I know I was talking about funding.
It was just like
talk about the time of day when you're busy.
So the reason I say that is because if it is something that we can bill for, we don't want to just provide you a clinician 40 hours a week where we're not going to see any income come in from it. Something's got to give, even though we take a loss on this. We shouldn't be taking a $70,000 loss, right? If we're taking a $30,000 loss, it's better than $70,000. So they do give us the data, and they'll say, like, Monday through Friday from the time of 10 a.m. to 4 p.m. is our highest call volume. Great. So that's when we supply them a clinician. We usually start at 8 because we want them out on the cruiser right away. And then like we just did this with Plymouth. So Plymouth did the same thing. They thought Friday, Saturday nights was their busiest night.
That's what
I
I
would've
would have
thought
thought.
too, right.
Yeah, that's
until they pulled
really
their data
surprises
and they were
me.
like, oh, that's actually not the highest call. So it's
Interesting.
once they stopped pulling the data, they realized I had no idea that would be the highest call volume.
Was it consistent with their town too?
It
or
was.
that
So
the same?
they do require a second shift clinician in
Yeah.
Plymouth. There's 75% of the causes mental health out there.
Wow.
Yeah, they have a huge mental health issue out in Plymouth and substance abuse issue. New Bedford does too, but 75% of their calls is mental health.
That's interesting. I wouldn't have known that. I would have
Yeah.
thought that.
There is a state grant out there that is for jail, what they call jail diversion, which is to supplement clinicians to do this job. So we have a couple of towns right now that are in the process of putting in for the grant, including Plymouth, to support any losses that we have financially. So a lot of the emergency service teams function under this grant, and we currently don't. So we get a call from a police department saying that they want to start a co-response program. I just say, show us the data. I will supply the clinician based on that data without having the grant. Ideally, we love the grant because it makes up some of the money that we lose.
Right.
But we know that we're a nonprofit. This is our job, is to do this role, and it is what it is. At the end of the day, it's the right thing to do for the community, whether we're getting income in or not. But it is nice if there is a grant. So there's a couple of like towns that are putting in for the grant. So right now we're in Dartmouth, New Bedford, and Plymouth active. And then we are in the process of being active in Fairhaven and Wareham, as well as Carver, Plimpton, Halifax, and Hanson.
Great.
So those are the places that are putting in for the grant that we're waiting for to start the program. And that's because they want to make sure to have it first as well. But if they didn't have it, we would probably still do the program regardless.
That's great. So you're a social worker. Your staff is all social workers?
Yeah, so I'm an LICSW. So I have staff all of our staff that do this line of work, that do evaluations, are all master's levels.
Okay.
So they're either an MSW with and have their licensure or non-licensure,
Right.
but they're all masters, or they're licensed mental health clinicians, which is the LMHCs. And then we also have the LDACs, which is it's more newer language for me, but it's a licensure, a master's level licensure for addiction.
Okay.
So we have those three typically, and we also you have to have your master's. You can't do this without having your master's. And we provide supervision to our staff for them to get their licensures. So we provide them free supervision so that they can get their licensures.
That's
so
like
I would say 50-50.
a 2-year journey, right?
It depends on your licensure. For social workers, you can get your LCSW right out of grad school because you already have your supervision hours. But to get your LI, such as myself, you need at least 2 years more after that. Where the LMHCs, they have to take their licensure. They can't be licensed for 2 years.
When you're hiring someone to do this type of work, what are you looking for in their background?
Yeah, so I am looking for somebody who is not intimidated. I am looking for somebody who's non-judgmental. And the reason I say that is when you're going into a police department, you have to remember that this is their home. This is their job. This is where they go to every single day. And there might sometimes, we all have things that we might say that might be offensive.
Right.
But if that's how they're venting, you need to be able to take a step back. And as long as it's not causing any damage to our patients and to you, and I say this to the officers during roll call, as long as you don't disrespect my patient and you don't disrespect my clinician, I might not agree with what comes out of your mouth for certain things, but I'm certainly not going to challenge you. And I think, having somebody know that, and I'm not saying that they're talking badly, but if things, we know very well that being a police officer could be quite challenging. And you need to have a place that you can just let your guard down. Just like we do, right? We all do it, right? We all have to decompress sometimes and just vent a little bit. So those are the things that I'm looking for. I'm also looking for a clinician that is very quick on their feet and are able to assess and make a decision relatively quickly.
Right.
Even though they're making a decision and they have to talk to an administrator on call, so they don't do anything independently. All decisions have to be approved by an administrator on call. You still have to be quick, and you have to make a decision to call your administrator on call and be able to say, here's what I found and here's what my recommendation is. And then your admin's either going to agree or not agree. And most of the time they're going to agree. But it does have to be a clinician that's very comfortable being out there and being vulnerable as well.
I think it's great that you have different levels of support out there as well. So like the officer is supported, but so is a clinician. Like no one's just out by themselves.
Correct.
Like doing things. And I think that is really a great infrastructure for success.
We have 24/7 administrators on call. So we, like myself, I used to do 2 overnights a week.
Yeah.
So if my staff are out on the field, they're calling me to talk about cases. During the day, we're usually the admin's there. Second shift, usually the administrator on call is present. But third shift, we do get a little bit of a break and get to do it from home, just so we can get some sleep in, because most of us have to go back in at 7 a.m. But again, the staff always have that extra layer that they can call.
Pam, are there some stories you can share with us, like that really a patient was or a person was impacted, because you were there with this program?
So I can tell you one specific story that we have an individual that suffers from schizophrenia, typically offers medication, typically does not allow anybody into the apartment, barricades himself in there for days upon days. And we did get a call from a family member for us to go out, and they went out. The individual would not open the door. Eventually, the clinician was able to get them to open the door and actually talk to them and get them the help they need. And I bring up this story because, fast forward a few months later, we get a call from the family at the crisis team saying, can you send out that clinician again? They did a really good job last time and got him the help he needed, and we need it again. So off they go again. And now they've had built that relationship with the individual, so their guard comes down because they realize, like, she's not there to cause you any harm. She's there to chat with you. So that, for that population, it does make a big difference.
Yeah, you must do a lot of support for the families too, then, I'm thinking.
Yeah, we do. I mean, obviously the patient's our priority,
right,
but it does impact all of the family members. So we spend a lot of time talking to family members, whether it's over the phone, in person at their home, or in our office, or at the hospital. They are part of, we do a lot of collateral work, and that collateral work includes the family members.
Now, we've talked a lot about this area in Massachusetts. Are there similar programs in our surrounding states like Rhode Island?
So Rhode Island does have the same program. They call it a little bit differently. They also contract with their local emergency service team. I only know that because I had a staff person who worked per diem for me who was doing it out there full time.
Oh, nice.
So it's a very similar program where they're out with the cruiser all day, responding to mental health calls. I do know that there is a couple of other states that do this program, but I think it's safe to say that, and I'm going to give credit to the emergency service teams out in the Boston area that actually started this over 20 years ago, that no one really knew they were doing this.
20 years?
Oh, yes.
Wow.
I didn't know that.
Yeah, 20 years ago, advocates started this program, and they're an emergency service team as us. So when I first started wanting to do this, I tapped into them and said, I need some guidance. Like, what do you do? Because we, even though we're a billable service, I needed to figure out, like, okay, if it's not somebody that we bill, how do we handle this? Yeah. So we call ourselves insurance blind, which means that, like, if it's not somebody we contract with, we just write a note. We don't bill anything. Because I don't want a person to get an $800 bill, even though it's not $800. Reimbursement rates are a lot lower than that. But I don't want them getting a bill in the mail.
Sure, of course.
So we just do a note, and they get nothing, and they still get a full service that we would provide them regardless. So they really, gave me a lot of information that was helpful to get us up and running. But they've been doing it for 20-something years.
That's incredible.
Very quietly, and no one really knew about it.
That's interesting.
Yeah, so I would say it's safe to say that, we definitely, as Massachusetts, is in the forefront in regards to this program. It's taken a little longer for other cities and towns to catch up to it, but everyone's slowly catching up to it. So we do we do a quarterly meeting with the police co-response with the state, where we talk about, like, things that are working, not working.
Yeah, I had just a thought as we're talking through this. I mean, a lot of times paramedics are the first ones who are called. Do the police always show up, or
They do.
They do. So yes, you don't need a separate type of system for that. Okay.
So it's interesting because New Bedford and Plymouth are very different when it comes to this. Like, a lot of times in New Bedford, it's just the officers that are showing up first. Where in Plymouth, they're getting dispatched, but so is the ambulance.
Okay.
So it makes it a little bit more tricky for us, because if you have an outpatient psychiatrist that's Section 12 as a patient, and our co-response clinician goes out with the officer and the ambulance is there with the Section 12, and our clinician says they don't meet Section 12 criteria. We just completed the evaluation. And so we've had to work through some kinks with the local ambulance company to say, and with the local, with Beth Israel and Plymouth, where we're able to have a conversation with the doctor in the emergency room to say, we've already evaluated them. They're not meeting inpatient criteria. They don't need to go to the emergency room. So that's been a benefit to it, but it was a little bit of a challenge at first because they're like, no, we have this pink paper. And I'm like, okay, but if you bring them to the hospital, we're still going to be discharging them because we're the team that's going to go in there and see them, and we're going to clear them. So let's not waste that money sending them there because we've already cleared them. So it's a little bit trickier in that area just because it's more of a team approach out there in the sense of all these individuals go out. We are working on that little by little. And the good thing is that the ambulance crews are open to this and to feedback and working collaboratively with us on this. So it's been a good partnership, even though it's there's a little bit of trying to figure out like how do we navigate the system. They're willing to work with it.
Yeah, I mean, there's a certain level of finesse with this, and just the experience that you can draw upon has to be a relief to some clinicians that maybe aren't as familiar with certain approaches and strategies to use. So yeah, give me all the help I can.
Absolutely.
So it was interesting that you collaborate too with on the bigger picture with programs that have been in existence. So when you started 4 years ago, like where your stop point was 4 years ago must be so different from where you are today. Yeah. And where are you going? Like where you see yourself going with it?
I feel like we've molded our program to what works for us and what works for our community. Like what we do in Bedford is different than what we do in Plymouth and what we do in Dartmouth. So you have to adjust based on the community that you're providing a service for. So how we do our program might be totally different than how Advocates does theirs. But there's so much that you can learn from what they've done that you can take, and even if you have to adjust it differently to your town and your city, you still have to give kudos to a program that's been doing it for so long that you've been able to
have
hear.
The recipe that you can tweak.
Correct. Yeah. So we basically just molded it the way we needed to mold it and figured it out. We figured it out day by day. We've had some bumps on the road. I failed to mention that anybody who's under arrest, if the courthouse is closed, it's our responsibility to evaluate them if they say they're suicidal before they can actually be brought in to jail. We have to evaluate them to clear them. So this program has been beneficial because if it's a holiday and they're working and the court's closed, we're doing those evaluations during the day, not just second and third shift. And not a lot of emergency service teams are doing that, which we do. And we find it to be a help to the police department, a help to the patient, a help to the House of Correction. By the time they get there, they've been cleared. And we're able to say, like, yes, they're depressed. Yes, they have passive SI, but they're not suicidal. And they can come and you guys can watch them.
Nice.
So this has been a wonderful discussion. Unfortunately, I think we're getting to the end of our time. Yeah. But if there was one message that you wanted to leave with our viewers out there, what would it be, Pam?
To me, it's, I always feel never judge. When you see somebody out in the community, never ever judge. I'm a true believer that we're all one step away from something happening to us as well, and that we need to be mindful of that. So when you see someone struggling with mental health, be a support and not, be positive, not negative.
That's a great message.
Yeah, and that to me has always been my train of thought and how I was raised by my parents and how I hope to really plant the seeds to my staff.
I think that's so important, even now where the economy is as it is, and there's so much stress and financial stress. There are a lot of people out there that are really on the verge of losing what they've had. And we've seen that. And it's a great message that we have to look at everyone. We can't judge. We have to look at people as we would want to be looked at. Right?
Correct. Absolutely. Yeah. That would be my takeaway.
Great. How do people reach you?
So our number is 508-996-3154. That is the 24/7 call number that covers all of our areas. We have one call center. So you will always get someone to answer the phone and you will never be placed on hold. And that's one thing we don't do. We don't put, and it's typically clinicians that are answering the phone. You can call us just to get information. It doesn't have to be just about evaluations. And we're able to provide, that information. We can call just to talk. Okay. Some people call just to talk, and we have a lot of repeaters that we listen to on the phone.
That's wonderful. So you're doing like some counseling on the phone, basically.
We are.
Yeah, right.
Yeah.
So that's great to hear. So if you can just repeat the number again, we'll post it, but
It is 508-996-3154.
Great. All right. Well, thank you, Pam, so much.
Oh,
It's
thank
been
you for
a pleasure
having me.
to
I
have you here.
appreciate
We
it.
learned a lot. I learned a lot. I didn't know about this
I
program.
did too.
We don't have it in Fall River yet. It sounds like it may be coming here. I hope we have it soon.
Yeah, I
Sounds
hope
like
you
it's
do.
been a great program in the areas that you're in. You've done a lot of great work. So thank you. And
Well,
thanks
thank you for having me. I
presenting this.
appreciate it.
And I want to, of course, thank our sponsor, Bay Coast Bank, which is right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Thanks again for watching the 27th Degree with Chris and Nancy from 27 Degrees Consulting. We'll see you again in a couple of weeks.